about pulmonary disorders, which you commonly get to see here at the facility, and some overview and how to deal with them, and to see if we can catch them earlier on and prevent readmissions and help the patients faster. So I'm just going to spend a couple of minutes on flu, because I get a lot of questions asked by patients, and sometimes the patients would actually ask the staff in my office. They want to know, should I get it, should I not get it? Then we have these people who have conspiracy theories, and they're always like, this is just a scam, I don't think it works, it's made by the pharmaceuticals, they're just selling the so there's a lot of stories about the flu. And then of course you always hear this one, which is, every time I get the shot, I get the flu from it. So just a little run on the flu. Recently somebody asked me, and they said, we don't think it works. So what do you think, Doug? So what I told them was, I gave them an example of polio. So 50 years ago, we used to see a lot of patients who would get polio. But then once the vaccine got invented and the vaccine was given to people, the incidence of polio decreased significantly. So I explained them the way they figure out the vaccine works or doesn't work is, before the vaccine is invented and before it's given, you look at the death rates from flu. So the death rate from flu used to be very high before the flu vaccine was given. And after the flu vaccine was given, the death rate due to flu decreased dramatically. So there is mathematical and statistical evidence that the flu shot does work. It decreases the death rate significantly. Some of my friends up north, we chat sometimes on group text, and they were mentioning that there are already documented cases of flu up north. So I think it's just a matter of time. Probably within a few weeks, it's going to be here. All of you guys who work at the nursing facility should be vaccinated, because you are in direct contact with your patients. And also, there's a good chance if you get the flu, you're going to take it home and give it to your children or the loved ones. So at least you should all be vaccinated. Then the other question which comes up is, if I get the shot, am I going to get the flu? Or I get the flu. So the answer to that is, you cannot really get flu from the flu shot. And the reason being, because the virus which is injected is a dead virus. Now, what can happen is, you can get a reaction from it. A reaction which seems like it's flu. You could get a little fever, you could get a little bit of body aches, some fatigue for a few days. So you can get a reaction from it, because remember, how does it work? So what we did was, they take the dead viruses and they inject it into your body. So your body now thinks it's a real virus, it's a live deal, it's a real deal. And what does it do? It forms antibodies against the virus. Now when you're forming the antibodies against the virus, the reaction is very similar to a real virus. So some people, most of us, we don't get any reaction from it. But some people, their body kind of gives an exaggerated antibody response to this virus, and then they get a little bit of fever or chills. Now those are the people who go around the street and tell everybody they got flu after getting the flu shot. They just got a reaction from it. And of course, if somebody gets a reaction from it every time, probably they can skip it, it's fine. But most of the people don't get a reaction, and they should definitely get it. It doesn't have any major harmful side effects. There are some contraindications to it. If you're allergic to eggs, then you shouldn't get it. If you had Guillain-Barré syndrome in the past, you should not get it. But there's some rare contraindications to it. So that's one of the things that you guys can do to encourage patients to get the flu shots to prevent respiratory disorders. We get a lot of admissions to the hospital because of the flu. They're all unnecessary. Most of them, if they've had the flu shot, and the flu shot, if it worked that year, then they wouldn't get that sick. So in order to understand respiratory disorders, let's go to the first picture. you have to understand what the respiratory tract looks like. Can you make it a little bigger? There used to be something here at the bottom.
Yeah, they update.
So anyway, that's a picture.
Oh, I found out.
Okay, that's good enough. So that's a picture of a respiratory tree or respiratory system there. It kind of includes the sinuses in the top, includes the oral cavity. Oral cavity goes down into pharynx, which is a common place where food and air both go through. But then it goes down into larynx. Now larynx is the place where we have a voice box. This is where we speak, and food is not supposed to go there. Neither is the water. Water and food is supposed to go into the esophagus, which is a tube behind the larynx. So below the larynx we have trachea. Trachea is a big tube in the middle of the chest. When you breathe, air goes through that tube, and then that tube divides into two bronchi. Bronchi are two big tubes coming off the trachea, and then these bronchi divide into multiple tubes, which are called bronchioles. And these are like branches of a tree. So once you breathe, air goes through trachea, it goes through the bronchi goes through the bronchioles, and then ends up in sacs. Sacs are like grape-like structures, and they're called alveoli. So the alveoli, they have very, very thin membranes in the tip, and these membranes are run by, there's a lot of capillaries which are running through these membranes, and that's where the gas is exchanged. So you take in oxygen, and the oxygen is supposed to move through the alveoli and goes into the capillaries, and the carbon dioxide, which is the waste product, comes out of the capillaries into the alveoli and is breathed out. So that's a basic structure of the respiratory system. So we can go to the second slide. So these are some common respiratory disorders. Yeah, you don't have to worry about the ones on the top, you know, the tonsillitis, laryngitis, the common cold is very common, but the good news is it doesn't kill people. There's always a little confusion. People think if they get the flu shot, they're not going to get the cold. So the cold has to be differentiated between a cold and a flu. So flu is actually an influenza virus which would affect your respiratory tract and can cause you to get pneumonia. Common cold, most of the time, does not affect the lower respiratory tract, usually affects the throat, the sinuses, and the upper respiratory area. So there are two different things. Flu shot does not prevent you from getting colds. It will only prevent you, hopefully, from getting the flu, which is caused by influenza virus specifically. The colds are usually caused by rhinoviruses and different viruses, and there is nobody has figured out how to stop that. So then the cases, the other diseases like bronchitis, pneumonia, emphysema, and then asthma. These are the ones that you guys mostly see, and you know you get hospital admissions due to these. Let's get out of this. Let's look at number 2. So we can just go to the first one. Okay. Remember I was mentioning about the alveoli, which are at the tip of the bronchioles. So if you look at a picture there of the healthy alveoli, you can see they've got nice divisions, nice walls in between, and through these walls you have the blood vessels which are running through these walls. Now a condition called COPD or emphysema specifically will usually lead to destruction of these walls inside the alveoli. So if you have destruction of these walls, you're going to have less capillaries or less blood vessels available to exchange the gas. So most of the people who have emphysema usually are short of breath all the time. The other relative of emphysema, which is a similar condition, which is also lumped under the COPD, is chronic bronchitis. So the difference is, in the chronic bronchitis, what happens is, if you look at the one on the right-hand side, that's a healthy bronchiole. Bronchiole was, remember, the tubes which take the air to the tips close to the alveoli. So you will see that in the chronic bronchitis, there's a lot of thickening of the walls of these bronchioles. So you can see on the right-hand side, since it's a big hole, the air can move through easily. On the left-hand side, because of the thickening of the wall, the hole has become extremely small. So the amount of the air which is going to be flowing through that is going to be a lot less. The other thing that happens in chronic bronchitis is that you're going to get excessive secretions. So the yellow stuff there, this is basically the lining of the bronchioles, the cells which line the bronchiole, they secrete excessive secretions. So in chronic bronchitis, what you're going to notice is most of these people, they will cough a lot, and they will keep on bringing up phlegm a lot. And there is a clinical definition of chronic bronchitis, which is consecutive cough for 2 months, for 3 months in a year, for 2 consecutive years. What causes chronic bronchitis? Usually exposure to smoke. So the commonest reason people in the United States would have chronic bronchitis is because of excessive smoking. In underdeveloped countries, one of the common reasons, smoking is still in the top, but another common reason is women are using wood as a fuel to make food or to heat the homes, and they get exposed to smoke. And of course, factory smoke, factory workers, or people who deal with the chemicals, they also are prone to getting both of these conditions, the emphysema and chronic bronchitis. Both of these things are lumped together under COPD. So when somebody says they have COPD, they probably have either more of chronic bronchitis and less of emphysema, or more of emphysema, less of chronic bronchitis, but they usually have a combination of both those diseases. So I think it's still a very, if you look at the hospital admissions after the chest pain, probably COPD exacerbations is still one of the very high up on the list. Now, working with Medicare, you know, when we looked at the admissions privately outside in our offices, and we tried to see what are the admissions that can be cut down to the hospital and can be treated outside, COPD is one of them, really high up on the list. And over the past 4 or 5 years, we have come up with strategies on how to cut down these admissions to the hospital. So we noticed most of the people with COPD, what they do is they get a cold, and then they get something called a COPD exacerbation, or exacerbation of their chronic bronchitis. And what they do is they think that they will get better. They give it time. But unfortunately, it never gets better. It just keeps on getting a little bit worse. And finally, they can't breathe, and then they end up in the hospital. So we identified all these people who have documented COPD, chronic bronchitis, and we came up with a plan, and we told them, we figured out that if they were to come to the offices, as soon as they got the beginning of the COPD exacerbation, they can be easily treated. And these people, they get treated with steroids, IV steroids or intramuscular steroids, and antibiotics. Something that you guys can give here in your facility, and something that we started giving in our offices. So we noticed that with proper education for these patients, we trained them that if you have a problem where you start producing more, so how do you know you're getting COPD exacerbation? Well, the way you know it is you start bringing up more phlegm than usual. So you have your regular phlegm, and now you start producing more phlegm. Normally you're producing clear colored phlegm, now you start producing yellow colored phlegm or green colored phlegm. So change in the color of phlegm, more excessive phlegm, more excessive cough, more excessive shortness of breath, or presence of some type of temperature or fever. So those are the things we teach them, and we say, if you start getting this, please come into our office. And we would like to treat you earlier on for COPD exacerbation so that it doesn't get worse and you won't end up in the hospital. And that's what we did, and we were able to cut down the number of hospital admissions very, very significantly. And of course, we get them on flu shots to prevent them from catching the flu. You can get out of this. Let's go to the second picture, see something interesting. So what are the symptoms of chronic COPD? It's basically chronic dyspnea. If you have chronic bronchitis, you'll get wheezing and cough and sputum. And since these people can't exhale the air, they get something called air trapping. So the air traps into the lungs and expands the lungs. They complain of chest tightness on and off. And because they have to spend a lot of effort on breathing, some of their calories, they get consumed, and a lot of these people with bad COPD will actually lose weight. So they'll get weight loss. Can get out of this. So the major culprit, as I explained, was in the developed world is smoking. It's still the top culprit. And you can see with chronic smoking, what happens is your alveoli, which is these grape-like structures at the end, they kind of get damaged, and it kind of shows you a picture of what happens to them. So all the patients with COPD, of course, you have to come up with a strategy on how to get them off the cigarettes. And if they can stop smoking, it will halt or slow down the progression of the disease. You can never get it reversed, but you can always stop the progression of the disease. So different techniques are available. You know, we have patches, we have Wellbutrin, we have the Chantix. So there are different approaches available. Now we don't succeed all the time, but with adequate encouragement and treatment, it is possible to get some of the people off the cigarettes. You can get out of this. I think this is the same picture, once more emphasizing the difference between chronic bronchitis and emphysema. We don't need that. The second folder. Is that the second one or third one?
This is the third one.
Okay. So the third one is pretty common. This particular problem, everybody has heard about that, pneumonia. So what is pneumonia? What happens in pneumonia? So in pneumonia, what happens is you get an infection, either it's due to a virus or it's due to a bacteria, and it usually will affect the alveoli. Alveoli is again the tips of the grape-like structures where the oxygen exchange is happening, and it creates a lot of inflammation. Now from this inflammation, you will get a lot of secretion of fluids and liquid. And this fluid and liquid starts accumulating into those sacs. So now basically part of the lung where you have the pneumonia is drowning. It's for practical purposes, you have added a lot of fluid into that portion of the lungs, so now air does not move or come and go through that part of the lung. So if you look at the x-ray, it kind of shows up something like this. I'm sure you guys have seen x-rays like that. So normally the x-ray is supposed to be all black, the lungs are supposed to be black because they're full of air, but once they get full of fluid, they show up like that. Now what's the difference between congestive heart failure and a picture like that? In congestive heart failure, the fluid accumulates on both sides. Pneumonia is usually, it's one-sided or one lobe of the lung. Of course, people have clinical symptoms with it too. They will have fever, have chills, high white count, and cough, and sometimes phlegm. Now, having said all that, once people start getting older and they reach extreme ages, sometimes they don't have all that. They don't get chest pain with pneumonia, they don't get fever. All they do is they get confused. So somebody will bring a person to the office and say, Dad has been confused for a couple of days. And that's when you have to figure out what it is, either it's a urinary tract infection or a pneumonia or something like that. So pneumonia is definitely high up there as cause of confusion. But again, if you do the x-ray, or if you do the, a lab on them, you're going to find out that the white count is abnormal and the x-ray will show the pneumonia. Most of these, of course, need to be treated with antibiotics. So the antibiotics, they will usually, most of the time you'll give a broad spectrum antibiotics to begin with, something like a Levaquin or Z-Pak or Cephin or something of that type, which will cover most of the organisms. Now, up here, You can have people, if they have been to the hospital, many times, they could have resistant organisms. So they have to use special type of antibiotics which would deal with those. The treatment for the COPD exacerbation. So if you have an acute exacerbation of COPD, the standard of care is to give them antibiotics. Rocephin is a great antibiotic which works. Azithromycin is a great antibiotic which penetrates the lungs. Levaquin is not the first choice, but definitely the third choice there, along with combination of steroids. So that would usually get a person out of COPD exacerbation. Let's get out. The inhalers that we use for COPD usually have some type of combination of steroids and a combination of beta agonists. The beta agonists, what they do is they open up the bronchioles. The steroids, they usually decrease the inflammation in the lining of the bronchioles. So one was COPD exacerbations as a cause of respiratory distress, which is very common. The other one was pneumonia as cause of respiratory distress, which is also quite common. Then there is asthma. So asthma is also very common, except most of the time you're going to see this in younger population. So older population, most of the time chronic bronchitis and COPD. Younger population, usually asthma. What's the difference between asthma and chronic bronchitis? The pictures, they look very, very similar. You can see that this is a normal bronchiole, a tube through which the air can move. And you can see that what happens with asthma is there is constriction. Remember in chronic bronchitis I explained that the whole lining of the tube becomes thickened and inflamed. In asthma, it doesn't quite become thickened, it constricts. So the muscles around the bronchioles usually will squeeze and constrict. Now asthma usually happens because you breathe in something in the air, an allergen, which normal people don't have a problem with. Maybe I'll give you an example, it's a pollen. So some person breathes in pollen and normally we don't react to it, but his body thinks that he is inhaling some type of poison and his body tries to fight it. So when it tries to fight it, mostly all the reaction happens in his lungs. So now what's happening is the bronchioles are constricting so that the poison doesn't go into his lungs. So that's what asthma is. And of course there is inflammation which produces excessive secretions. So people with asthma, when they cannot breathe, the body thinks that it's actually protecting them against something that they breathed in and it was very poisonous. So if I was to go into smoke, if there was a smoke in a building and a normal person enters the smoke, what's going to happen to me? My body's going to do the same thing. I'm going to get constriction in the bronchioles, I'm going to start getting cough because my body's trying to get me out of that place and trying to prevent the smoke from going in. Except in asthmatics, it's against pollen, or it's against something which is not supposed to be that harmful, but the body gets tricked into thinking that it's something bad. So asthmatics, so one of the differences in the asthmatics, if you give them the beta agonists and steroids, you can immediately reverse the reaction. In chronic bronchitis, it takes longer time because there's inflammation, it's chronic inflammation, it's scarring, it's thickening. In asthma, it's just constriction. So you can give beta agonist and open up the bronchioles so the air starts moving in. So of course, lots of nebulizer treatments, steroids, and if you think it's an infection which caused exacerbation of asthma, then antibiotics too. There's actually still about 4,000 people that die from asthma every year. So some people just have an extreme cases of asthma where their body reacts very aggressively to everything. Here's another one. Yeah, let's do that one. Okay, this one is very interesting. I just put it in there because it's very dramatic. It happens once in a while. I think every couple of years, 2-3 years, we'll see one, I'll see one. So normally your lungs, right inside the chest cavity, lined up nicely against the chest wall, the ribs, and they're nicely expanded. So what happens is, lung tissue is elastic and is always wanting to collapse. Now why doesn't it collapse? But the reason it doesn't collapse is because it's touching the chest wall. So since it's touching the chest wall keeps the lungs open. So if I was to put a hole into the lung, the air from inside would just leak outside between the lung and the chest cavity, the lung would just collapse. And that's exactly what happens in this condition called pneumothorax. So in the pneumothorax, what happens is one of the parts of the lung, there's a tiny hole there. So the air leaks from the lung and goes outside into the chest cavity and the lung just collapses. So what's the, how do you figure that out? Well, you figure it out. There is a person who is usually short of breath because it happens most commonly in people with emphysema and COPD. Why does it happen in them? Because their alveoli, remember, there has been a lot of destruction in the alveoli, so they've got weak walls of the alveoli. So once in a while, one of those will just rupture. As soon as it ruptures, air will leak out into the chest cavity, lung collapses. So it's dramatic. So you have a person who is walking across the hall, maybe he's short of breath, all of a sudden, he will collapse. Either collapse, complains of severe chest pain, or becomes excessively short of breath. So it's just a very dramatic type of picture. And of course it needs immediate assistance. You get a chest x-ray and you will immediately be able to see pneumothorax. They do have chest pain, by the way, too. If it's bad enough, something called tension pneumothorax, in which what happens is more and more air starts getting trapped into the chest wall and starts pushing the heart towards the other side. So those people, they'll become blue. So they'll become cyanotic. You get their oxygen saturation. It's dropping. They were normal a few minutes ago. Now they're collapsing. That you can't do anything about. You have to send them to the hospital. there's no way out of it. So how do they treat it? Of course, they just put a tube down here into the chest, suck the tube air out of the tube. So once they suck out this air, the lungs just will expand. Anyway, yeah. Or in the TV, as they show you, put a needle in there. Yeah, on the a needle. You could, yeah. Anyway, so we can get out of this. So that's a dramatic condition which happens in people who have chronic COPD. Usually that's the commonest cause. Yeah, that's just another picture. We can have a look at that. It's just basically a nice picture of showing you what actually happens. The part of the lung collapses. We can get out of this. So you can see the right lung nice and big expanded, and the left one got a pneumothorax that collapsed. Are you sure? Okay. So just a couple of other words. So if you see a person who's short of breath, you know, in your facility, you see someone who's short of breath, you gotta, the million-dollar question is you gotta figure out what's causing it. Now I give you some examples of, you know, the COPD exacerbation. The typical thing with the COPD exacerbations is if you put your stethoscope at the back, you're gonna see that they have some whistling sounds or wheezing sounds in the back. You can also sometimes hear a lot of congestion. And of course it goes with the story where they've got cough and producing phlegm, or they've got fever. Now, if you had a similar patient who was short of breath and they had congestive heart failure as cause of the shortness of breath, how would you be able to tell the difference? Well, if you put a scope on them, usually you hear crackling sounds. Usually the crackling sounds are at the lower part of the lung. And if you come up towards the top part of the lung, the crackling sounds usually will go away. If you try to lie them down, most of the people who have congestive heart failure, they'll be sitting on top of the table or sitting up, and if you try to lie them down, they'll tell you, no, that is no good, they can't lie down. So a person who cannot lie down, has got crackling sounds, has got no fever, has got no wheezing on the lungs, the chances are they probably are having fluid as a problem. If you have somebody who is fine and has a dramatic shortness of breath, that usually would mean tension pneumothorax, but you don't see that too commonly, thank God. If somebody, of course, is complaining of chest pain along with it, and they have signs of congestive heart failure, they're probably having a heart attack. That's why they've got congestive heart failure. If somebody complains of chest pain, they're short of breath, they're coughing, they got phlegm, they got fever, most likely you're dealing with a pneumonia. So simple things to do in this case is you get an x-ray, get a blood count because you want to make sure the hemoglobin is okay. That's another reason you can get short of breath. Pulse oximetry and the vital signs. Thank you.